Welcome, everyone, and thank you for joining us today for our special edition webinar, New Options for Heart Valve Patients, Results of the Latest Clinical Trials. So hello, everyone, and welcome back to those of you who have joined us before. And we welcome you, especially if you're joining us for the first time. If you're new to us, you may not be familiar with Heart Valve Voice US. We are a patient-led organization that exclusively focuses on improving diagnosis, treatment, and management of heart valve disease by advocating for early detection, meaningful support, and timely access to appropriate treatment for all people affected. And we encourage you to find us online at heartvalvevoiceus.org, sign up for updates. We want your voice to be part of this organization. You can also find us on Twitter and Facebook. And I'll introduce myself. I'm Susan Strong, and I'm Director of Patient Engagement at Heart Valve Voice. I've been involved since the beginning and was president of the board at the start. And I'm also a patient like you. And this November 12th will be my 5-year TAVR anniversary. So it will be a happy anniversary to me on November 12th. I'd also like to introduce John Lewis to you. John joined Heart Valve Voice in August of 2019. He's our executive director, and you'll get to actually see and hear John in just a few minutes when he interviews the two physicians that we're going to be speaking with tonight. And next, we are very fortunate to hear from two distinguished leaders who are advancing science through clinical trials, and both have made significant contributions to the field of structural heart disease and in transforming patient care. It's my honor to introduce Dr. Mark Russo, Chief of Cardiac Surgery and Director of Structural Heart Disease at Rutgers Robert Wood Johnson Medical School, and Dr. Tamim Nazif, Director of Clinical Services at the Columbia Heart Valve Center and Director of Clinical Research for the Center for Interventional Vascular Therapy. Thank you both for giving your time today to educate and empower heart valve patients.
Thanks for having us.
Thank you so much. It's a great pleasure to be here.
Thank you. We'd also like to thank Edwards Life Sciences for sponsoring this educational patient webinar series. So thank you for that. And we're going to start this evening with a video interview that took place recently at TCT 2019. It's a conference in San Francisco. And Mark and Tamim, you both sat down for a conversation with John Lewis, our executive director. Could you give patients a little bit of context here? What is TCT and why is that important?
Sure, I'd be happy to do so. TCT is an annual conference that's called Transcatheter Cardiovascular Therapeutics. It's run by the Cardiovascular Research Foundation, which is a not-for-profit research and educational organization dedicated to heart and vascular disease. And this is an annual national meeting attended this year by more than 11,000 people, including many cardiologists, including interventional cardiologists, the type of doctors that do TAVR procedure, as well as cardiac surgeons like Dr. Russo, who's also on the call with me. This meeting focuses in many ways on innovative science and new solutions for our patients. At this meeting, as well as many of the prior meetings, some of the trials, the clinical trials related to TAVR and other new technologies and techniques in valvular heart disease have been presented. We also do a lot of teaching such that not only is the new science presented, but additional doctors around the country are able to learn more about the therapies and even practice, for example, techniques in hands-on simulators and those sorts of things. So it's both a scientific meeting, but also an educational opportunity for doctors from around the country and, in fact, around the world.
Wow. Well, thank you so much for taking time out from that meeting to participate in an interview with us. We're excited to see that in just a moment. I want to address our viewers real quickly to let you know that after the video portion, we'll respond live to your questions. And for those of you who are watching live with us right now, during the video would be a great time for you to type your questions into the chat if you're watching on your computer. So I think now, without any further ado, let's watch this video interview and then we'll come back for live Q&A.
Hello, I'm John Lewis, Executive Director of Heart Valve Voice US. Welcome to our webinar series. Today I'm joined by Dr. Mark Russo, Chief of Cardiac Surgery and Director of Structural Heart Disease at Rutgers Robert Wood Johnson Medical School, and Dr. Tamim Nazif, Director of Clinical Services, the Columbia Heart Valve Center, and Director of Clinical Research, the Center for Interventional Vascular Therapy. Thank you for joining us.
Thank you.
Thanks, pleasure to be here.
Our topic today is going to be the expansion of TAVR to a new patient population that we're all very excited about. I know both of you have been involved in TAVR and in the research for a long time. It must be very gratifying for you to see the continued expansion to more and more patients over the last 8 or 9 years, I guess. So we had some developments over the summer with the FDA approving TAVR for low-risk patient groups, and then following that, a national coverage decision for Medicare. So we have the coverage and the approval, which is how it should be. And I think one thing that might be important to clarify for patients is when we talk about low risk, what does that really mean? Who is now eligible for this procedure that wouldn't have been previously?
I think if you look at the previous studies that were done in TAVR, the extreme high risk and intermediate risk, all three of those studies, the average age, patients were in their 80s, about 83 years old. The patients in the low risk study, the average age was 74. So it's about patients who are 10 years younger. The other things that we look at is something called STS score, which is an estimate of the likelihood that patients won't survive 30 days after a surgical AVR. And then we also do frailty assessment to see just overall condition of patients. And those three factors are largely how we risk assess patients. But I think the easiest thing for patients to understand is this is a much younger population that didn't have a lot of other medical conditions, unlike the previous populations that we studied.
Okay, Jim?
I think that's exactly right. I think you have already correctly mentioned that the average age has decreased into the 70s, and many of these patients are functional folks, many still working without substantial medical comorbidities. So, patients that in the past would certainly have required surgical aortic valve replacement and potentially have a life expectancy of 20 years or more with a valve in place. So, brings up some of the issues that we're going to be talking about, I think, in this patient population.
Yes, I guess with the younger population, one of the issues may be the durability of the valve and the durability of the procedure itself. Can you address that?
So, I think that it's important when we see the results of these trials to really discuss who are the patients that these therapies are most appropriate for. We now have a choice. In the past, if you had severe aortic stenosis in this risk level, you would have a surgical aortic valve replacement. Now you have a choice between two therapies. And it's not necessarily that one is better or worse, it's that there are different relative advantages. I think that the trial of the balloon expandable platform, as well as the self-expanding platform, the trials demonstrated that in the short term, the patients generally were in the hospital for a shorter period of time and had a more rapid recovery of a good quality of life. That may be one of the major advantages. At 1 year, there were some signals that there might have been slightly enhanced safety in some patients. So I think the patients need to weigh those perhaps shorter term benefits to some of the potential longer term issues. What we don't know about TAVR is what the valve durability, for example, is.
Okay.
We have good data from the higher risk patients out to about 5 years. We have a sense that towards 8 years, 10 years, but because we've been doing surgical aortic valve replacement for more than 60 years now, we know clearly the surgical valves last out to 15, 20 years and beyond. We have to be honest in the discussion with the patients about what we know and what we don't know. We know a lot about the short-term favorable aspects of the procedure, and I think those need to be balanced against some of the questions we're still learning about with the longer term.
I agree with everything Tamim said. I think one of the really important things about this study is that we're going to have such long-term follow-up, not only on the TAVR valves, but also on the surgical valves. There are many studies that have been done on the surgical valves, but probably none that have so closely scrutinized the valves for such a long period of time. To have 10-year data on both valves, 10 years from now, we'll really be able to tell people, what to expect as they go through their life, because these are patients that we would expect many of them to easily live another 10 or 20 years. And so it's not just about, what happens this year or next year, but really looking at the long term, and maybe even, some patients may live long enough that they outlive their valves and they need additional procedures, and how are we going to address that? It's really, it's such an important study, and we're going to keep learning from it over the next decade for sure.
There's also, I think, an interesting paradigm shift as we talk about patient risk and we say low risk. Because of the way that the trials have evolved, and because we started with high surgical risk patients, when we say risk, we talk about surgical risk. That's what we're referring to. What's the risk of the patient having a surgical valve replacement? But the field has evolved to the point, and our pre-procedural screening, especially with CT scans, has evolved to the point that we can talk not just about the patient's surgical risk, but about their TAVR risk. And I think that's an important thing, to make an individualized risk assessment for the patient for both now of the two choices, and then to try to give the patient a sense of what the relative risks for them as an individual. So it's not just any more low risk for surgery, who's low or high risk for TAVR, right? And we can talk about some of the patient subsets that may be more or less favorable for TAVR, not just for surgery.
And that was my next question. What group now would you categorize more to be in the surgical category? And I think surgical is another term that can be confusing for patients, because from a patient perspective, it may all it's all surgery. But for the distinction between surgery and the transcatheter procedures, what group now is in the surgical group most likely? What are their factors?
Probably some the younger patients, I would say. We would favor surgery. People who have other concomitant cardiac disease, that is, they have mitral valve disease, or they have aortic aneurysms or severe coronary disease. Those patients are probably still better addressed with surgery. And also bicuspid patients. Bicuspid patients we have some data on, but probably not enough data to say for sure with confidence that we can offer TAVR with good long-term results. And also the bicuspid patients, the patients who have bicuspid valves, typically are younger. So again, that also favors surgery.
I completely agree with Mark. We have a relative paucity of data in very young patients. So patients that are, say, into their 60s and younger, you might still favor surgery. Bicuspid, significant concomitant coronary or other heart disease, for example, mitral valve disease with aortic valve disease. And then I would add that subset that I was alluding to of patients that are, for one reason or another, higher risk for TAVR. We understand now that TAVR is most favorable if it's performed from the femoral artery access, from the groin area. What if a patient has blockages in the leg arteries and we would need to do a TAVR through a different alternative access? That's probably less favorable. There's patients, for example, that have coronary arteries that are too close to the area where we're going to put the TAVR valve. That's an anatomic risk factor that the TAVR may be higher risk. There's some patients that have very robust calcium, such that a surgeon could debride or remove that calcium, whereas with a catheter valve, we might expect to have a risk of bleeding around that area or a risk of leaking around that area. So there are these pre-procedural categories that we can define of patients that may be less suited for TAVR.
Okay. Those are such important points. Up until now, we've largely had to look at patients based on their surgical risk. It's really only looking at one side of the risk, but there's risks to both procedures, to surgery and to TAVR. The surgical risks are largely related to comorbidities, age, frailty, those sorts of things. The TAVR risks are, as Tamim said, are largely anatomic. The size of the root, where the coronaries are, calcium distribution. Access issues, and so they're very different. But you really need to consider both, I think, if you're going to make the best choice for the patient. And we really have the opportunity to do that now, where we can. In the past, you may have seen a patient that you really felt like would do better with TAVR, but they were low risk, so we couldn't offer them that. And now we have that ability.
Mm-hmm.
Right.
And when you mention that you may have patients with both aortic and mitral valve issues that would be more suited for surgery because you could do both valves at the same time, essentially.
Yes.
Okay.
That's exactly right. Yeah.
clarify.
Another interesting point is, I think this brings up the importance still of the heart team. We talked a lot in the early days of TAVR about the heart team, which means that the patients are evaluated by both a cardiac surgeon and a interventional cardiologist, and that it's discussed together in a patient-centered fashion with a shared decision-making process and really bringing in the patient's values and wants. And I think that remains very important. The NCD that you mentioned stuck, I was very happy to see, in the low-risk patients with that recommendation that the patients really should be seen by a heart team. Mm-hmm. And I would say that probably applies to all of the patients with aortic stenosis.
And an important part of the heart team is the patient.
Absolutely.
The patient, part of the process needs to be, we haven't addressed this, shared decision making. What are the patient's expectations? What do they want to achieve from undergoing treatment and getting their preferences and understanding their lifestyle and all the things around that.
And we see that not uncommonly. So for an example of this would be, I might see a low-risk patient and the patient comes to me and says, I'm still working on my most important thing right now is to minimize the time that I'm away from work, or maybe it's my family, or I have something coming up that I want to address before, and I want to have the least amount of time in the hospital and the quickest recovery. Well, then we can offer TAVR. That's the patient's goal. Some other patient might say, I want to minimize the number of procedures I have over my lifetime. I want to choose what we know the most about the long-term result. That might be a patient that you might talk more about surgery. So I think it's very important to incorporate these individualized values and wants of the patients into the medical decisions, assuming that both are appropriate.
How do you start those conversations with the patient? Or because the patient may be quiet or just trusting of your opinion. I think now we're seeing patients more engaged in their health, maybe more informed, hopefully more informed about different choices. But how do those conversations start generally?
One of the things that's really satisfying about this field for me is we have so much information that objective data that we can share with patients. We can tell them we can tell them with reasonable certainty what the risks of the various approaches are, what they should expect from recovery. So that's usually where I begin. I try to tell them, what's the risk of adverse outcome, what should they expect in terms of return to full function, those sorts of things. And I think that it makes the discussion so much easier because they have a real sense. There's a lot of other things we do where it's just not as well defined as in this field, and again, because this patient population has been studied so well, we have a lot of information to share with patients.
Particularly in some of the higher and intermediate risk patients, there are some shared decision-making tools that have been developed, and it's been a fairly fertile area for research. And I think now that we have low-risk approval, some of that research will be useful to help to characterize and develop how to best involve patients, particularly lower risk patients, and to begin to think about what the important considerations are for those patients.
Good. You had touched on some of the general research results earlier, and there were, I guess, two large trials here. There was the Evolut trial with the Medtronic valves and the Partner 3 trial with the Edwards valves. And focusing on the Partner 3 trial, it was a randomized trial, 1,000 patients, about 500 received TAVR, 500 received surgery, so I think quite well designed. What were, and the primary endpoints you were looking at there were death, stroke, and rehospitalization, I think were the three primaries, and then some others. What can you share about those results, and what have you experienced from your involvement?
Well, I think first of all, patients in both arms did very, very well. The results, the rates of death and stroke are very low in both arms. Much lower at least in the short-term data that we have. Much lower in the TAVR arm. The reduction of mortality at 1 year was about 60%, and the same for stroke. And actually, rehospitalization was a third part of the composite endpoint that we captured, and there was a 30-ish% reduction in rehospitalization in the TAVR arm. But nevertheless, the surgery patients still also did extremely well, better than we would have predicted based on their preoperative predicted risk.
Right. I mean, I think, if anything, I agree with Mark. The results in both arms of the trial were extremely good. Speaking to the evolution of the TAVR field and the improvement in safety, there was a rate of death and major stroke in the TAVR arm of 1% at a year. It's incredible. You would never have dreamt of that or dared to dream of that 10 years ago. So I think, TAVR has really evolved and matured. I think, as Mark alluded to earlier, the surgical therapies have also, the surgeons have gotten better through this whole clinical trial effort as well. So both arms did very, very well.
Yeah.
The death and major stroke was statistically lower in the TAVR arm at a year. Some of the relative complications of one versus the other were different. You might have more pacemaker or left bundle branch block conduction disturbances in the TAVR arm, for example, but you might have more atrial fibrillation and other types of arrhythmias in the surgical arm. So there's some more subtle differences in the complication rates. What was notable to me, and I think important to some of the patients, was the time in ICU as well as the time in the hospital was fairly dramatically lower in the TAVR arm. And if you look at quality of life, by 1 year it's similar, but at 30 days, it's clear there's a much more rapid recovery in that TAVR arm.
And that's one of those measures that's very important for patients that we often don't capture in the clinical measures is the quality of life.
Right.
Does that come up in your discussions with patients too and your subsequent follow-ups with them?
Yes, but I'm also not hesitant to recommend surgery in a patient for whom that's the most appropriate therapy, because as I said, by 1 year, both arms had very good results and very good quality of life improvements.
Yeah. The previous study suggests that after about 3 months, between 3 and 6 months, the initial quality of life is better for the TAVR patients because there's less recovery related to it. But probably closer to 3 months, the two groups usually converge and have the same or similar quality of life. So it's just a different time scale.
Do your discussions with patients go into the level of the type of valve they're getting and how that valve acts, or does it go to that level? Are they curious? Are they asking those questions?
It's not uncommon for people to ask what the valves are made of, both the valve tissue, where they come from, to ask about the stent. I readily show people the videos of the valve deployment because I think that helps them understand the whole procedure and how you can see the valve, but to see how it actually works, because the concept is almost like a magic trick, right? I mean, that you could through a needle, you could replace somebody's valve. Yeah. It's an amazing technology.
And do it live here at the show. They've been beaming in all week. But
yeah,
yes.
I agree with Mark. I think a picture's worth 1,000 words. So I frequently will show the patient a picture, an animation, and we even have valve models that will sort of pass around, and the patients and their families can actually hold the valve in their hand and see sort of what it looks like, what's the stent frame, what the leaflets are. The other discussion that becomes important sometimes is what medications a certain type of valve might require. If you have a surgical valve that's mechanical, made out of metal and plastic, that requires lifelong anticoagulation or blood thinners, and that becomes a certain, for certain populations, younger patients, because it has very long durability, something we recommend, but has important implications for the medical therapy that they need. The TAVR valve, we use two lighter blood thinners, whereas with a bioprosthetic surgical valve, you may not need that. So I think there are some differences with the medications that a patient might need that they're also appropriately concerned about and want to know.
In the mitral valve area, we're seeing some expansion also in approval of clips and other types of devices, and there's several more in development that I think are maybe 2 to 4 years away from being approved. What do you see going on in that space?
Yeah. Mitral is a rapidly evolving field. It's, in all honesty, the mitral valve is more complicated than aortic stenosis in terms of its mechanism. Whereas aortic stenosis has, maybe 2 or 3 different mechanisms or 2 or 3 different etiologies. There's many for mitral disease. So unlike aortic stenosis, where you can imagine just a few solutions, in mitral there's probably going to be many different therapies that we're going to have to explore, and maybe even understand different combinations of therapies because it's complicated, because it is more complicated. But we already see with MitraClip and some of the early replacement devices a lot of progress, and I think the field had moved slowly at the beginning, but it's now picking up a lot of momentum where it seems like you can imagine a variety of different options in the near future.
I agree. As the TAVR field has really matured, now the new area and the exciting frontier that we're talking about is the mitral valve, and to some extent even the tricuspid valve, which is a related valve on the right side of the heart. As Mark correctly said, these are much more complicated valves and more complicated disease states. The shape is much more complicated. The patient can either have a problem with the valve itself, or they can have a problem with the heart around the valve, and the treatment of those two things is quite different. We have right now the only approved therapy is the MitraClip. That's been approved for some time for people that have an actual problem with the leaflets themselves, but only if they're not candidates for surgery. In that disease, surgery really works very, very well and is very low risk. On the other hand, surgery hasn't worked so well for patients where the valve leaflets themselves are okay, but the heart is stretched out or there are other problems around the valve. And that's where the clip, we've had the COAP trial in the past year that showed in those patients that have what we call congestive heart failure, due to the heart being stretched out and the valve not working well, really benefit with respect to mortality, heart failure, hospitalizations, and so forth from this clip procedure. That's now being approved. And I think that's where we're going to see real growth in the clip. And it's leading to a lot of excitement for a whole host of other types of devices on the leaflets, around the leaflets, and different ways of trying to address this problem.
It's very exciting because it's really the first time that we've been able to find a therapy, particularly for the functional MR patients, as we call them, that Naeem just described. This is really the first time that we've been able to show really a profound benefit of any therapy. And so the new data just came out, the 3-year data, and the data just looks better with each iteration. So it's very promising.
Great. Any concluding thoughts?
Look, I think it's a tremendously exciting time with the low-risk approval on the TAVR side. I think we're still going to learn about the best patients to use it in. I think we're going to pay close attention to the longer-term results. And I think, as we've just said, these catheter therapies are only going to continue to expand with explosive growth into the mitral area, into the tricuspid area, and beyond. So it's a really exciting time, I think, for the patients, and stay tuned.
Yeah, it's very satisfying to have these new therapies where before TAVR, there was probably about 65, 70,000 patients who had their aortic valve disease treated in the U.S. And now, that number has been pretty constant. And now, in addition to that, there's another 80,000 patients who are going to undergo TAVR probably in this year. So now you're talking about going from being able to help 65,000 people to almost 150,000 people, and that number is going to keep growing. So it really has had a profound impact on patients' lives.
Tremendous. Well, thank you both, and thank you for staying on for the upcoming Q&A.
Real pleasure.
Thank you.
Thank you.
Well, thanks everyone for watching the video. Lots of great information there. I have a general question to start with for the doctors about just in general. A lot of patients are quite anxious when they find out that they need to have a heart valve replacement procedure or surgery of any type, and oftentimes are looking for reassurance that they're making a good decision about their treatment. And so I'm wondering what you could tell us about the safety of valve replacement in general and the risk of not treating severe symptomatic aortic stenosis.
Yeah, that's a great question, and something that we speak a lot about with our patients. I think it's important to emphasize, particularly when it comes to aortic stenosis, that this is a lethal disease with a prognosis in the absence of treatment worse even than many of the feared cancers that we talk about all the time. However, unlike many of those diseases, aortic stenosis is now eminently treatable. And that's one of the things I think you heard about in the video recording, that the results in both arms of the trial were really excellent with respect to safety. So if a patient is appropriate for TAVR and gets TAVR, that's great. That procedure has really, really evolved such that the recovery can be incredibly rapid. Oftentimes these days, our patients, especially the lower risk ones, might only be in the hospital for 24 to 48 hours. Many times they don't need general anesthesia. They frequently go to the regular part of the hospital after their procedure, recover, walk around, and they're able to go home in a very short order of time. Even though for the patients that need surgery, surgery has also evolved, as I pointed out, and I think Dr. Russo can speak to this even more. Those patients these days also have a much, much more rapid recovery. Do you want to comment on that, Mark?
Absolutely. I agree with it. Naeem said. Sorry, am I echoing here? What I always tell patients is the good news, or the bad news is that they have aortic stenosis. The good news is that we have great options to treat them. Obviously there's great outcomes with TAVR, and as Tamim said, with the surgical arm, the outcomes were actually better in the most recent low risk study than we would have otherwise predicted. There's more focus on rapid recovery after surgery. We've often extubate our patients in the operating room, and not uncommonly send patients home a few days after surgery. With both therapies, they've advanced so much over the past decade with how closely we've studied it, that if patients have aortic stenosis, there's really little question that they should seek treatment, because as Tamim pointed out, the alternative is almost certain death, whereas with treatment, patients can expect in most cases to go on and live many years, even decades after therapy.
Thank you. So another question on a lot of patients' mind centers around durability of the valves. And in the video, Dr. Russo mentions that 10 years from now we'll have great data, but unfortunately there are patients right now that are trying to make a decision about what to do, and there's been 5-year data published about TAVR and the valves. With what we know about surgical valve durability, I hear surgical valves can last 8, 10, 12 years on average. How far are the TAVR valves really off from that, do you think? Or what is our best guess, even though we don't necessarily have the data yet?
This is an excellent question, and it is one thing we're talking about as well frequently with our patients, because there is a data gap. There has been some 5-year data showing that in general the valves tend to hold up well. There was recently presented at the TCT some 5-year data from one of the prior balloon expandable Edwards trials. However, it's important to recognize that trial didn't use the most current version of that valve. So these valves aren't just one thing that's stayed the same over time. We're now on to the third, and in some cases even the fourth generation of the Edwards valve. And when we look at the data from the prior trials in the medium risk, what we call intermediate risk patients, the results were even better using the newest, sort of latest, greatest valve from Edwards. And we don't have nearly as much long-term data in that. So I think what we can say confidently to the patients is that preliminary data suggests that things look reasonable out to 5 years, but what we really know the most about right now is the 1 to 2 year time frame. In that shorter term, TAVR does seem to be a little bit safer, particularly if done from the leg, but we just don't have a great sense, certainly out to 10 years. Whereas with surgery, because we've done surgery for so much longer, there's a better long-term data available, and that's one of the things that will weigh with a patient when they're trying to decide between one treatment and another.
It is one of the trade-offs where we know with TAVR that the short-term recovery is faster, but that we have much better long-term data on durability for surgical valves. So it's always, I think, the question that patients need to struggle with. Anecdotally, we don't see a lot of failed TAVR valves, and TAVR has been done. The first TAVR valves were placed in very small numbers, even dating back to the early 2000s. Large numbers weren't implanted until about 2011 when it was commercialized in the U.S. We're starting to get to the point where we're having more long-term durability data on TAVR, but we're not quite there yet. So there is still some uncertainty around it. I expect that TAVR valves will have better durability than we expect. There's no way to say how they'll compare to surgical valves, but hopefully we'll have that data in the near future.
It sounds like an important part of the shared decision-making process between a patient and the provider, and a sense of a person's individual risk tolerance and what their values are in the short term and the long term.
Absolutely,
Absolutely,
100%.
it's probably one of the most important questions, or maybe the most important questions for patients who are appropriate candidates for both therapies.
Mm-hmm. Mm-hmm. Something that hits home for me as a survivor of Hodgkin's lymphoma with a history of mantle radiation, high dose mantle radiation, 36 gray to the chest. These for those types of people who were considered high risk previously, is TAVR probably a better option because of the risk for surgery, especially multiple open heart procedures in those patients who've had radiation?
I would say that that's one of the great things about TAVR, that we are able to offer what is a relatively low risk procedure to patients who would otherwise, if the only option was the alternative, would be a very high risk procedure. That is, there's patients who are high surgical risk, but they're actually lower TAVR risk, and the patient population that you're included in, I think, fits there. And it's one of the reasons that we're able to treat so many more patients. As I mentioned in the video, before TAVR, we would replace about 65,000 surgical valves annually, and now we can replace 150,000 surgical valves. There's just so many more patients who can benefit from this.
Yes. I've got a question too about the decision that was made, the Medicare decision. The question is, I understand the Medicare TAVR coverage policy was recently updated. What has changed, and does a patient still need to be evaluated by 2 cardiac surgeons and an interventional cardiologist? And are there other changes to the process as a result of that?
Yeah, I think that's an important question. The NCD coverage decision, which is what's being referred to, was announced this year over the summer, and it evolved in some important ways from the prior Medicare coverage decision. The specifics include that a patient must still be seen by a heart team, meaning at least 1 cardiologist and 1 cardiac surgeon, but not 2 cardiac surgeons. And I think that helps to ensure patient access and ease some of the logistic challenges around seeing 2 different surgeons. So now patient will see the heart team, but 1 cardiologist and 1 cardiac surgeon. Also, the risk level distinctions were removed from the decision, such that before it said we'll cover, for example, high risk patients, we'll cover intermediate risk patients. Now it said patients who qualify for an FDA approved indication will be covered. So the concept of risk was withdrawn, such that the minute the FDA approved based on these low risk trials that we've been discussing, we were able to immediately offer it to our patients. So that was something quite favorable. And then there's some more subtle changes to the requirements for doctors to start, for example, a new center or to continue doing the procedure around adequate experience so that it can be done safely and effectively for as many patients as possible.
Yeah, the initial national coverage decision, I think, largely focused on trying to ensure the best quality, because it was and limiting too rapid a diffusion of the technology because it was new. The more recent national coverage decision really focuses on the importance of expanding access and easier access. One of the things that we really try to do is decrease the number of appointments that patients need to see, because it can be frustrating for patients to need to come to, say, 3 or 4 or 5 different physicians. As Timmy pointed out, you only need to see 1 cardiac surgeon under Medicare. One thing I would mention to patients, though, is if they're privately insured, their private insurer's rules may differ from Medicare, and often the private insurer's rules lag changes in Medicare. So if some patients may still face that, which can be a barrier, because it requires, in some cases, the patients have multiple visits with multiple providers.
Yeah, thanks for bringing that up, Dr. Russo. I'll just throw in here a resource for patients who could be having issues with insurance approvals is the Patient Advocate Foundation. we can add the link to that as well, that they actually can help individual patients interact with their insurance about trying to get approvals. And then another question about bicuspid patients. The bicuspid patients were excluded from the main clinical trials. Does that mean that bicuspid patients can't qualify for TAVR, or where do they fall in with this opportunity to have TAVR as a treatment?
This is another great question. It is correct that the large randomized trials have excluded bicuspid aortic valve disease. These are people that are born with 2 pieces to their aortic valve. We call them leaflets instead of 3. And that's 1 to 2% of the entire population are born with that type of bicuspid valve. If one has bicuspid valve, there's a higher risk of developing either aortic stenosis, blockage of the aortic valve, or aortic regurgitation, which is leaking of the valve. And it tends to happen at a somewhat younger age. It can also be associated with things like aneurysm in the aorta. And in general, it's still one of the reasons which we might favor surgery. There's certainly in that area more evidence to support the use of surgery to replace the valve, as well as potentially to fix the areas of the aorta that are abnormal if necessary. That's not to say there's no data in the area. There's what we call registry data, meaning patients that have been treated, but outside of the highest level of evidence, the randomized trials that we've been discussing. Those registries have shown that in selected patients, meaning patients that had anatomies that were appropriate for the catheter valves, meaning their own heart valve was the right size and shape, that the results could be relatively favorable. But I think it's fair to say that in general right now, we are only doing TAVR for bicuspids if they're really high risk and not good candidates for surgery for one reason or another, or if they're participating in some type of clinical trial. In general, for patients that are at lower surgical risk, this is one of the areas where we still favor surgery in most cases.
Anything to add, Dr. Russo?
Nothing. I think that was a very good summary.
Okay, great. Thanks. A question about patients, especially the younger, low-risk type patients who might have mild coronary artery disease, and they might need an intervention in the future. What considerations in terms of valve choice procedure for younger patients to be aware of to ensure that they have all options open in the future if they need other types of interventions?
So the area, and I think I mentioned this briefly in the video, the area where the arteries lies is in very close proximity to the valve. And when you put in a transcatheter valve, it further decreases the area leading into the coronary arteries. This can sometimes become a challenge when one has to go back and do an additional procedure inside of the arteries. That's something we call percutaneous intervention. If people have heard of angioplasties or stents, those are devices used similarly with catheters to open blockages of the arteries. And one has to go right next to the valve to access those arteries. We're beginning to learn that some patient anatomies and some of the transcatheter valves are generally easier to work through in terms of getting back to the coronaries and performing an intervention down the road. In general, the shorter a valve is and the larger the openings in the frame of the valve near the artery, the better. And so this is certainly another type of topic when we talked about the shared decision making and discussing the relative risks and advantages of a procedure. You know, it's not just TAVR versus SAVR, transcatheter versus surgery. It's also, if you're going to get transcatheter, which type of valve, and different valves may be better for different things. So I think that's another important aspect to be discussed.
It's the anatomical aspects and planning for the procedure are so important in TAVR, and understanding that different patients have different anatomies, and therefore some solutions are better. And again, that could be surgery, that could be TAVR, that could be different valves. But that's why the standard of care for all patients is to get a cardiac CT so we can really understand the anatomy. Sometimes additional echo is necessary for more information. But the anatomy, understanding the anatomy prior to a TAVR procedure is really, it's crucial to success for the procedure, not only in the short term, but also over the long term.
And the anatomy and the valve that's chosen in a TAVR procedure can have an impact on the need or potential need for a pacemaker. Is that correct? Could you explain a little bit more about that?
That's absolutely
Typically,
right. You know, sorry, go ahead, Mark.
No, I was going to say that typically balloon expandable valves have lower pacemaker rates than self-expanding. That doesn't mean that there's not a role for self-expanding, but overall, if you look at the available data, it would suggest that balloon expandable is the risk is lower. The nerves that make the heartbeat run near the aortic valve, and anytime we manipulate the aortic valve, we can disrupt those nerves. Different patients and different procedures have different risks. Typically, surgical AVR has a slightly lower pacemaker rate than TAVR, and typically lower risk patients should expect a lower risk of pacemaker than higher risk patients. The risk of pacemaker can vary depending on the patients of the procedure, probably anywhere between 5 and 15%. Typically, what I tell patients is the risk is overall 1 in 10, but there's other factors that play into that, and so depending on if patients have certain risk factors, we may have a more extended discussion about their risk.
Anything to add, Dr. Nazif?
No, again, I think it speaks again to the importance of understanding the technology and understanding the relative risks and benefits of each option and talking to them. It is true that particularly as we speak about younger and lower risk patients, it's things like risk for pacemaker, ability to get back in the arteries and do future procedures, the ability to have as little leak around the valve as possible. These relatively subtle differences that maybe we didn't worry about quite as much in patients, for example, in their 90s, might be much more important and relevant in a patient in their 60s or 70s that might live with this valve for a much more extended period of time. So as we look at the pre-procedural planning, and that's really these days focused on the CT scan, that's a critical piece to look at the anatomy, as Dr. Russo said, and really try to decide what valve is most appropriate for the patient, and to consider these additional factors that we've mentioned.
Yes, Dr. Nazif, you lead me to another question when you mention living with a valve for many years. Can you tell us a little bit about the valve-in-valve procedure? And is that only for original TAVR valves? Can that happen with surgical valves? Can you tell us a little bit more about that?
Absolutely, and that's another great procedure that we've really learned a tremendous amount about in the past 5 to 10 years. And valve-in-valve TAVR is potentially appropriate for patients who have either failed transcatheter valves, they had a TAVR in the past that started to wear out and either get blocked or leak, or a bioprosthetic, a biological animal tissue surgical valve. There's a certain type of surgical valve called the mechanical valve. That type's not appropriate, but the majority of the patients have biological valves. They might have been told that they had a cow valve or a pig valve, for example. Those valves might also be appropriate for a valve-in-valve procedure if they begin to wear out. That's not just true for aortic valves, by the way. If a patient had a mitral valve replaced in the past, or even a tricuspid valve, those patients might also be eligible for a valve-in-valve procedure. It's best studied in the aortic position, and it's approved in people that are elevated risk for surgery. And I think it's likely we're going to continue to investigate, and more patients will likely be eligible for that. It's one of the reasons that we are trying to ensure now that all patients get as big of a valve as possible, that their anatomy will accept, whether they have TAVR or a surgical valve replacement, such that in the future, if they need it, it's easier to go back and put a second valve inside of the first valve.
Okay, and so you're doing that valve-in-valve procedure not only in the aortic position, but also in the pulmonary and mitral.
Yes, indeed.
That is great news. A lot of people do ask about, what's happening with the mitral valve position and transcatheter. Can you tell us a little bit more about the future of that?
Yeah, as we said in the video, the mitral valve is a much more complicated anatomical structure. The disease is also more complicated. So, whereas the aortic valve is relatively circular, the mitral valve is described as being more of a saddle shape. It's not completely symmetric. It can be affected in several different ways, either by disease processes affecting the parts of the valve itself, the leaflets, or diseases that affect the heart muscle around the valve and cause it to stretch out. So it's a much more complicated situation. It's not entirely clear that there'll be a single solution that works for all patients. Right now, the only thing that's approved in the United States is that MitraClip procedure we mentioned, a procedure where you go and clip the two sides of the valve together to reduce leaking. There's a number of other different things being studied, either related to modifying the leaflets, to putting different types of bands around the valve, to doing full-on valve replacements. But these are areas in general still in the research domain. And I think looking forward to conferences like TCT over the next several years, you're going to continue to hear a lot more about these technologies. But in general, they're not ready for the majority of patients yet.
Okay. And are there TAVR trials still going on in, say, for asymptomatic patients or moderate aortic stenosis? Or are they doing clinical trials on bicuspid valves?
There's many trials. There's trials looking at new types of valves. As you mentioned, probably one of the most important trials, or maybe the most important trial in the space going on right now, is looking at treating asymptomatic patients. The current guidelines suggest that we should wait for patients to actually develop symptoms before we offer them therapy. There's a couple problems with that. One is that sometimes it's difficult to tell if people have symptoms or not. Aortic stenosis is a slowly progressing disease, so often people think they feel more fatigued or short of breath because they're getting older, and they don't attribute those symptoms to some other specific cause, particularly a cardiac cause. Also, as the disease progresses, it can do damage to the heart that becomes irreversible. So as we look at the data, many people believe that if we treat patients earlier, before they even develop symptoms, that they'll have better outcomes. So there's a study called the early TAVR trial that's going on looking at treating asymptomatic patients. There's likely going to be, there is one study looking at treating patients who essentially, it's a little more complicated than this, but patients who have decreased heart function and have only moderate aortic stenosis, because we believe that we may be able to provide that patient population some benefit by earlier treatment. And then one of those studies may expand to look at just moderate aortic stenosis. So there's definitely, it's an expanding field, and it may be that there's not only new therapies to treat people, but there's new indications, and that we may be able to provide benefit to a broader group of people than we even previously thought we could.
That's really important. Anything to add?
No, I agree completely with what Dr. Russo said. A lot of exciting continued trials going on.
Yes. Well, we're getting to the last 2 or 3 minutes of our webinar. Is there any parting thoughts that you would like to just leave us with as far as outlook for patients or outlook for the future for treatment, or just anything you'd like to say? It's kind of free for you.
Great. Well, first, I'd say thank you for the opportunity to be here. It's been a real pleasure and a lot of fun. I think as I mentioned in the video, that this is just an incredibly exciting time for the field, for our patients in particular. For the first time now, we have a choice for the majority of patients. And I think that's really exciting. I would encourage all patients who are told that they have an aortic valve problem, aortic stenosis, or a heart valve problem in general, to discuss new options, to educate themselves and discuss all of the options with their physicians. Um, we now have such great ways to take pictures, to image the heart with both ultrasound and the CAT scans, and really to try to understand in an individualized fashion what's best for each individual patient. So that for me is something. We went from an era where many of our patients had no option to now see our patients have multiple options. It's a different world that, like I said, was hard to imagine even 10 years ago, and really tremendously exciting for the patient. So it's a good a good time for the field, and hopefully to the benefit of the patients.
Thank you.
Absolutely, it's so great because we've developed such a strong evidence base to be able to understand who should be treated and be able to guide patients on what their expectations should be after treatment. It's one of the things that's so satisfying about this field is that we can really talk to people in an educated way and give them a sense of their risks and the benefits of moving forward and with each of the different options. This is probably the most well-studied cardiac condition that we treat. There's again, the evidence is just so robust, and so it's great to have opportunities like this to be able to educate patients and share knowledge so that they can make the best decisions for themselves.
Thank you. I have one follow-on question that came to mind after what you both shared. Thinking in terms of choice that's available now and the opportunity for patients to become educated, and I think there's an opportunity for patients to advocate for themselves as well. What do you think about getting a second opinion? Sometimes patients are hesitant to do that or ask about that, but if a patient goes to one appointment and perhaps is not given a choice, do you think that's a good time, or is any time a good time to kind of get a second opinion and find out kind of multiple thoughts on how to treat an individual's situation, disease?
Well, I think there's certainly nothing. Sorry, go ahead, Mark.
No, please.
I was going to say, I think there's certainly nothing wrong with getting a second opinion if one is ever unsure or uncomfortable in any way. These are still important and meaningful procedures, so it's worth learning everything you can about it before going through it. Some patients may see their doctor, they may have a good relationship with the doctor, they may understand what's said and be immediately comfortable sort of making a decision and moving forward. There are other people that may require additional information. A second opinion is fine to get, doing additional research, talking to their primary doctor as well can give them additional comfort. So I think it's very individualized for a patient to decide for themselves. You can get in a situation where you have too many opinions too,
Right.
and then that can become another trick to deal with that. So I think the best thing is for patients to understand themselves and to be comfortable with the information and to feel free to get a second opinion if they feel that it's necessary, but not to feel compelled to do so either if they feel that they can make an appropriate decision with the information they have.
Absolutely. Patients should educate themselves. These are big and obviously life-changing decisions. If they're uncomfortable with the information that they're getting, then it's probably worthwhile to seek additional opinion. I would say, but even more than getting a second opinion, I would say is getting early evaluation and potentially early treatment. I think that that's the most common mistake that patients make, that they know that they might have this problem, but no one gives them a sense of urgency that they should really have it evaluated. I would say it's never too early to to have it evaluated, because those tests are relatively benign. There's no real downside to being evaluated and to making sure that your condition is not being underestimated, and that it doesn't require more urgent treatment.
Thank you, Dr. Russo. That is a very important point to end on, that it is very important to be on top of it and be evaluated and get treatment and not ignore aortic stenosis. We do have a couple of resources if people are interested in clinical trials that are ongoing. Clinicaltrials.gov and antidote.me are a couple of sources to look, especially if you are looking at other valves that are still in trials. And that concludes our webinar. So thank you all so much for taking an hour out of your day to join us. Thank you, Dr. Russo and Dr. Nazif, for spending this time with us. We appreciate it so much. So
Thank you. This is great.
concludes.
Thank you for having us.
Thank you. That concludes our webinar.